Thank you, Prof. Zhang. Morning, CEO and friends and colleagues. It's a real pleasure to be able to share with you our experience on the eye experience with partnering with volunteers. It's been quite an interesting journey, and I hope that you'll be enthused after this as well. So, I think the challenge that was put forward to the eye department was to see whether we could engage volunteers in a rather different tact, because usually we have certain perceptions about how we engage volunteers, and I'm just going to show how in this pilot we've been able to maybe up the ante a little bit and with some pretty exciting results. But I think as clinicians, we are very busy people, and to my mind, 3 questions popped up when I was thinking about working with volunteers. First, and let's be upfront, why should a busy clinician think about partnering with volunteers? And maybe, okay, volunteers for Milo and blankets, and maybe to man the help desk, but more, taking it a bit further. And wouldn't they be more hindrance than help? Because if we are going to take them a bit further, then we need to invest in them. And these are, people who may come and go. There's always been a sustainability issue that would come to mind. But I'd like to propose to you that partnering and enlisting volunteers may be more an imperative, and it may not be a want, but more a need. Why? Because a lot of we're kind of afloat at the moment because we have a heavy reliance on foreign domestic help. But that supply, that pipeline of domestic help may not be perpetual, because our neighbors may not always be willing to have their citizens come over to help us. But more than that, so you say maybe we can't rely on domestic help, we can rely on our families. But we also know that the new old, we're getting more and more who are singles because people are just not getting married that much anymore. Then let's say we rely on the healthcare manpower. But that's not easy as well, especially in the area of long-term intermediate care, because that's a heavy commitment and there's already such a heavy need within the more acute settings. So I think that I'd like to propose that we actually have a perfect storm brewing, one of an aging population, a shrinking workforce where by 2030 we have 2.3 working adults to every person who is 65 and above, tightening domestic help labor market, and more importantly, even if we were to rely on the healthcare manpower base, it might be problematic. On Monday itself, I was just having to share one PSA with 3 other colleagues because people were on MC, and it's just, the turnover with our patient service associates is high. So I think it's a real problem, but I think there is also help at hand. And this is a movement that I think is not only happening within Tan Tock Seng, but across the nation. So this was pulled out of Straits Times recently. I think it was in August, if I'm not wrong. And basically, more and more, we are actually engaging volunteers. In Tan Tock Seng itself, we had 100 volunteers in 2010, but by last year, we had 800. And they were clocking 33,000 hours, which is one executive for 13 years, or 13 executives for 1 year. So it's not a small workforce. But more than that, I think there's a potential multiplier effect, because one clinician can only reach out to so many patients, but an appropriately pitched project, and I think the key here is an appropriately pitched project, can actually help significantly more patients and reach out to significantly more places. But also, the intangibles, beyond the numbers, there's also the notion of what kind of health system we want. Do we want a passive system where it's going to be hospital and clinic-centric, where people seek treatment when they're ill, and then we deliver healthcare, but maybe with very little emphasis on health and care? Or do we want to broaden our perspective and start to think about people, patients, caregivers, the community at large, who form a not insignificant informal workforce? And also about the place, going beyond the boundaries of the hospital and clinics into community and homes. And more so about the delivery of care, looking at knowledge and awareness, self-care, empowerment, and maybe even the socio-economic aspects of illness and health. So we started with this hypothesis: can we partner volunteers to add value to the clinical care experience for our patients, beyond serving Milo blankets and manning help desks? But more specifically, are there gaps in our clinical care that would be difficult to fill, but volunteers maybe can possibly fill? So when we were presented with this, the eye clinic had this large window of opportunity. In 2016, we saw 140,000 patients. The average waiting time was about 27 minutes with a maximum waiting time of 131 minutes. If you base it on the 27 minutes and you times the number of patients we see, that's a colossal 3.7 million minutes, which is equated to 63,290 hours. The challenge was to see if we could use this time more meaningfully, because normally our patients, you just have to go to clinic 1A and you see. It's a very frustrating place for them because we have a long lead time, we have to dilate these patients. We can't shorten that waiting time, it's not possible. So I think the leadership put out this challenge. Let's see if we can use this time to value add. So we set up a team. We had our advisors, Dr. Mark Chan, Ms. Liang Hui Ting, and the rest of the team. And we tried to look at, and we, more importantly, enlisted a very amazing group of volunteers. I've come out of this project completely turned around. I become a convert because of them, because they were so dynamic, so enthused about the project, and they really exceeded my expectations. We looked at the clinic, we walked around, we did a walk around, and we identified 3 areas. Okay, the first one is a bit traditional, but also it's very important because our clinic is spread between 2 different places, in Atrium as well as in Clinic 1A. We also have a complex sort of system where patients have to go and get their vision checked, get registered, and then put this pink form outside the consult room. And we have had a few complaints where patients didn't know that they had to put the pink consult outside. So we don't know they're here already and it's been a few hours. So it's not a small area, but I would today focus on the other 2 areas. The Consult Plus service, where we look at basic history taking at the glaucoma and general clinic and showing patients the proper way of instilling eye drops, and patient empowerment. This is quite exciting, where we actually get patients to get our volunteers to help patients to do their visual field test, and you'll see why later. So the first one was about the glaucoma eye drops. Now, glaucoma eye drop compliance is a problem. About up to 50% of our patients do not use their glaucoma eye drops correctly. Just imagine this, because you could be on this drop, and this drop. And this drop you could be using maybe in both eyes twice a day. This drop maybe on the right eye once a night, and this drop in both eyes as well, twice a day or 3 times a day. And you're maybe 60, 70 years old, you've got rheumatoid arthritis, your memory is not so good, your vision isn't good because you've got glaucoma, and you're trying to put these eye drops. So we designed this as a checklist. Our volunteers approach our glaucoma patients while they're waiting in the waiting area, ask them, not tell them, but ask them with this pictorial checklist, what eye drops are you on? How many times are you putting it in which eye? And then we'll tick off here. The patient then takes this and passes to me. With just one glance, I know if this patient is using the eye drop correctly or not. I then tick off on this column the correct regime. I pass it back to the patient and explain with this what you're supposed to be on. They take it back. And we do this maybe 2 or 3 times. And if they're still not compliant, then we refer them to our glaucoma nurse clinician, who will then spend 45 minutes to teach them again one more time. We can't have 45 minutes for all our glaucoma patients. So what the volunteers have been able to do for us is to broaden our reach and allow us to really identify patients that need that extra help. It's a problem. How does this value add? This was a paper that was published in the Journal of JAMA some time ago, which looked at our local population, 2,781 glaucoma patients in Singapore. And after 1 year, only 22.5% are using the eye drops. After 3 years, it drops to 11.5%. And these patients are on what we call monotherapy. The patients that we are targeting in our clinic, they're on 2 drops at least, if not more. So based on 1 drop, your compliance rate at 1 year is only 22.5%. And glaucoma eye drops is applied to 90% of our patients. It remains the mainstay of treatment for glaucoma. So, why do we need volunteers? Doctors should be teaching them, correct. But this was a videography study in America by Harry Quigley and his team, world-famous glaucomatologists. Physicians spend an average of 8 minutes in the room with the patient, average of 5.8 minutes talking with the patient, of which 70% of the conversation is from us. And we only detected 27% of all the glaucoma patients who were missing the eye drops. These were our results. 103 patients that we managed to touch with through the volunteers. I think it's very interesting. 22.22% are sure that they don't know how to use their eye drops. Okay, that's fine. But this group here, 55.56%, are not sure either way. So they're not even sure if they are unsure. They're completely confused. And that's about 78% of our 103 patients who actually really don't know how to put it. Some actual cases. So Mrs. T, she's on this, we switched her from this eye drop Timolol to Xalatan. But we found out later through this project that she's still using all her leftover Timolol at home because she didn't want to waste her eye drops. Mr. A, he's supposed to use this drop Azop 3 times a day, but she's only using Azop once a day. Mrs. X, she's supposed to use Xalatan in both eyes, but completely left out the other eye and only used it in the right eye. What does that mean to us? This was before glaucoma, this was before the Consult Plus service. So traditionally, patients' pressure is uncontrolled. A significant proportion of them due to non-compliance, but we're not picking them up because we don't have the time. So what do? We change or add eye drops because we have to assume that the eye drop's not working. Still uncontrolled. Either they progress because they refuse surgery, or we have to escalate to surgery or laser. That's the real paradigm that we're faced with. And I'm very proud to report that after the Consult Plus service, we've been able to parachute and inject this extra layer of care for our patients through the volunteers to check for compliance and share on the proper way of putting their eye drops. And if they're still uncontrolled, we identify patients that need that extra help, refer them to the glaucoma nurse clinician for more extensive training. And if they're still persistently non-compliant, I think we can put our hand on our heart and say that these patients deserve and need surgery. Much more than, the sort of not very sure, but anyway, we have to do something. So I'm going to move to the next area, which is the visual field test. A very large problem for the eye clinic, as you'll see later. And I'd like to play you this video. You are going to do the visual field just to get a feel of what it feels like.
Once you're properly positioned, you will see a white screen. Right at the center of the screen is the fixation target.
So look
here
here
only. The target that you will have to keep looking at for the duration of the test. Once the test has begun, small white lights will flash at random at different locations on the screen. You will have to click on the trigger button to tell the machine that you have seen these flashing lights. Please remember that you have to keep looking at the fixation target at all times. You should not shift your gaze to look at the flashing lights.
How many of you looked at the flashing lights and not at the fixation target? It's almost a primordial sort of evolutionary reflex. You will look at something that presents to you suddenly in your periphery. And that's the problem we have. We do 14,000 visual fields a year. Each field comprises of 2 visits because of that large volume. One to do the field test and a second to consult the doctor. So it's 2 visits per test. We have a 46% rate of unreliable visual fields. That equates to 6,440 unreliable visual fields. If you times the cost, it's not a small cost. It's 275,000 wasted fields, worth $275,000 wasted fields. But more importantly, when we see an unreliable field, what as a clinician would you do? You don't know if the patient's glaucoma is getting worse, better, or stable. So you have no choice but to reorder tests and shorten the time to the next follow-up. And this then sets up a vicious cycle. So embedded within this 14,000 fields, to my mind, is a huge inefficiency. And we've not nipped the problem at the bud, right? Because we're still just ordering more tests, and the patient is more frustrated because they're going again and again for a test, and you are telling them that they're doing it poorly. Just some real examples. So this is a visual field test. So what you are seeing here is basically the black spots are the areas where the patient cannot see. This patient in 2012 had a low test reliability and had this field defect here, this black area here, which is like the top part of your visual field. In 2014, still unreliable, and it was kind of like that. And May 2015, still excessive high false positives, so still very unreliable. And then we had finally, because what happens is that our volunteers take a visual field test checklist that we apply to our patients just before they go to do the test. We finally had an accurate result, and to me this is really critical because actually this patient's visual field is a lot worse than we would have otherwise thought. Because when you're looking at the target and you click, obviously the computer registers as you can see, but it's actually not your peripheral vision. So before the introduction of this program, basically this is what would happen. We would just reorder and reorder and reorder. But now, with this extra layer of care again through the volunteers, we're actually able to say that if a patient is really in two scenarios, we can either get them more reliable because we're teaching them just in a very timely fashion just before they go in to do the test. Or if after repeated sort of help, they still cannot do it, at some point we should stop ordering because some patients just cannot do these tests. It's very difficult. So I think this is an area where we have actually had really quite encouraging results, and this is a summary of the total work that they've done, our volunteers. For 2 months, 7 dynamic volunteers, clocked 108 hours, touched our patients, 756 of our patients. I think it's quite stellar results. So overall, the iClinic experience with volunteers has been this. For the volunteers, I think they have made the leap into providing help that solves real clinical challenges. And they are, and the thing that encourages me the most is that they are prepared and actually want more challenging roles. For us as clinicians, I think we need to have a mindset change and be prepared to actually partner with them and look for areas that we can actually engage them so that we provide for patients more holistic care. And I'm just going to play a video for our project.
Hello. Are you seeing a doctor accompanying a family member?
I'm here with my mother-in-law for consultation. We've waited for a long time.
Let me introduce myself. I'm Lily from the iClinic volunteer program. The pink slip you are holding needs to be dropped in the box.
That was how I met Lily, who shared her volunteering experiences candidly. Inspired by her stories, my volunteer journey began. Volunteers who signed up for the iClinic volunteer program received training conducted by the eye consultant, Dr. Owen and Wai Cheng. Volunteers actively discuss, provide feedback, and co-create content of the training with Dr. Owen and Wai Cheng. They are very open to our suggestions, and I'm so glad we have a role in creating patients' journeys. The training session is definitely helpful as I'm equipped with the knowledge and skills to interact with eye patients. When I started my volunteering, I was accompanied by a senior volunteer, giving me the assurance and confidence to put into action what I've learned in the classroom. The iClinic program is exciting as there are 3 unique roles that volunteers can choose from. Care navigators and befrienders assist patients with wayfinding and registration by making sure patients place their forms outside the consultation rooms. Eye patients who go through visual field tests are often unable to comprehend the instructions, resulting in inaccurate test results and reorders. Visual field test ambassadors help patients prepare for the test by explaining the visual field test process in languages patients can understand. Consult Plus service ambassadors assist doctors with basic history taking at the waiting areas of the glaucoma and general clinics. They also perform patient education by demonstrating proper eye drop installation methods.
The volunteers are very friendly and they help me without me asking. They also teach me how to put eye drops properly and remind me when to use which eye drop.
When I first started as a volunteer, I was a bit hesitant, but having gone through a lot of training sessions, having more understanding of medical terms and issues made me a better caregiver. They actually got us, volunteers, doctors and the nurses, to brainstorm what they think is important so that it can actually benefit the patients waiting in the clinics and helps them with their clinical evaluation.
We have been able now, through the help of CHAR and the enlistment of volunteers, to actually derive this quite important clinical information while they're in the waiting area. And then once that's in, it's passed over to the clinicians, and then we can plan their management, plan their care that much better. I am confident that under the structure that CHAR brings to this whole program, we're going to be able to actually tap onto volunteers in a manner that would exceed our imagination and exceed our expectations. Yep, a big thank you to our volunteers, and indeed the journey continues. But there are challenges, of course, and I know some of them are already floating in your heads. Training takes time, it needs a structure. I think sustaining the interest of volunteers and the viability of the program is a challenge, but it's a vicious cycle. If we have meaty programs that excite our volunteers, then I think the volunteers would be more than happy to come on board. But we only just ask them to serve. Not that it's not important, I think it's important, but I think we need to have a good spectrum that will fit different sort of aspirations for our volunteers. They have aspirations too. And governance and safety was a real issue, and I'm really glad that our advisors actually highlighted that, and so we pitched it at a level that we think is safe, and building a culture where all of us are supportive with volunteers amongst us as part of our team. So my personal experience with the Centre for Healthcare Activation is this. CHAR, together with the volunteers, helped me realize some of the things I always wanted to do but really couldn't because there's just no bandwidth to do that because we are so busy with the clinical dimensions. So the second phase for us is really, I'm very excited. I think I've always been excited about patient-reported outcome measures, and this is from the International Consortium for Health Outcome Measures, where we look at not just the clinical parameters for success in treatment, but also the patient-reported outcomes using validated functional questionnaires. Who's going to do it? Where are we going to do it? I don't think we can hire manpower really to do this, and I think also it may not be good for healthcare professionals to apply this because there has been extensive research, some of which we've done ourselves through qualitative research, that if you get a doctor or a nurse to ask a patient, how are we doing it well? Well, you usually get an underwhelming of responses where you get this, everything is good. Yeah. So we hope that we can work with CHAR to really bring this to fruition. And this is the prototype that we're still working on, and we're going to get our patients, our volunteers to get our patients to use this before and after some of our treatment, and then measure the outcomes from a functional basis. Some of the stuff like, you know, how you're coping with your vision for computer work, for driving at night, for managing your daily activities. So there are exciting times ahead, and iTROM actually provides this for any specialty, almost a very wide range of specialties. But at the end of the day is this. That's my younger twin brother. We will all grow old, you know, and the question we must answer is, what kind of healthcare we want for ourselves? Because, like it or not, some of us may end up using this system. So with that, I'm very, very happy to actually invite Madam Idawati, our volunteer leader, to share her experience.